This is the last part, part 4 of Unit 13. Positive DATs overall are very difficult to understand, but the autoimmunes, as long as you have these different categories and know the procedures to follow, they're kind of easy. But drug-induced hemolytic anemia, students struggle with the most. And these are very rare, 1 in a million chance. And drugs may induce formation of antibodies either against the drug or against red cell antigens. Drugs may act as haptens once they're firmly bound to the red cell. Remember, a hapten is something that's very small, an antigen that's very small, that it's not detectable. But once it attaches itself to something else, then it becomes visible to the body and may stimulate an immune reaction. There are 4 theoretical mechanisms for drug-induced hemolytic anemia: drug adsorption, immune complex formation, autoantibody production, and nonspecific protein adsorption. Now, note in newer editions of the technical manual, they mention the following categories, but also categorized by activity. Most references still contain the categories listed above. So don't get confused if you see another way of categorization. So you may wish to copy-paste this diagram into a Word document for easy reference and then add your notes. I could not split it up into 3 different sections, which would have made my life a whole lot easier. The first mechanism we're going to talk about so far as drug-induced hemolysis is drug adsorption. Approximately 3% of patients receiving large dose IV penicillin will develop a positive DAT. Less than 5% of the 3% will develop hemolytic anemia. The mechanism: the drug is adsorbed onto the red cell in vivo, so it becomes a hapten. Penicillin becomes a hapten. If the patient develops antibodies to penicillin, they will bind to penicillin on the red cell, and the hemolysis occurs extravascularly. So anything that's recognized as foreign by the body is pulled out and destroyed. So extravascularly means that it happens outside the circulatory system. So this graphic illustrates, we see the red cell, which is the carrier. We see the hapten in green, which is the drug that is attached to the surface of the red cell. And then you see yellow, which is the antibody. And again, complement activates, hemolysis occurs. So how do you work this up? The DAT is strongly positive due to IgG coating the cells. In the serum or plasma, the antibody screen will be negative unless alloantibodies are coincidentally present. High-titer IgG penicillin antibodies present will only react with drug-coated red cells in vitro. In the eluate is reactive with drugs coated onto RBCs, and this test is available at a reference lab. Hemolysis is subacute at onset, but may become life-threatening if not recognized in time. And the solution: discontinue the penicillin. And that will stop this. Whatever drug is present will still cause hemolysis, but as the drug levels decrease, which I don't know what the half-life for penicillin is, then the hemolysis goes down. And this was such an interesting case. I've only seen one in my life, and I was the one who caught it. So the patient was D negative, I believe A negative. And so when I did the week D test, the week D test was 4+, but the negative control was 4+. And so this made me do a DAT, which was positive. The panel was negative, and the eluate was negative. And so I got the history. Patient was on penicillin. And so I'm assuming this is a case of drug adsorption, acute hemolytic anemia. And so I got some penicillin from the pharmacy, followed the recipe in the technical manual, but it didn't work. So we ended up sending it off to a reference lab. And this was published in the magazine Transfusion because these cases are so rare. This guy's hemoglobin, if I remember correctly, was between the 4 to 6 gram mark. But fascinating case, probably never see one again because, again, this is very, very rare. The next type of drug-induced hemolysis is immune complex formation. So the drug binds with the antibody in vivo in the plasma. This immune drug-antibody complex binds to the red cells and initiates complement activation. This leads to intravascular hemolysis. So remember, the first one we talked about was extravascular. This one is intravascular, within the circulatory system. This is what is the most dangerous part of immune complex. After the red cell hemolyzed drug antibody complex dissociates, it then has the ability to attach to a new RBC. Small amounts of the drug can result in acute hemolysis because the complex bounces from red cell to red cell to red cell and activates complement and boom, destroyed. Piperacillin, which is a synthetic penicillin, and second and third generation cephalosporins and anticeftriaxone have been implicated. So this picture illustrates the principle of the immune complex formation and hemolysis. So you see patient antibody in the plasma, the drug is in the plasma, and they combine. They form a complex in the plasma. This complex then binds to the red cell, activates complement, which causes destruction of the red cell. Then the immune complex will break off and go bind to another red cell. So this is why a very little amount of the drug can cause such a great deal of hemolysis, and this is intravascular. When working up this type of reaction, the DAT only has complement present on the red cells. The serum or plasma, the antibody screen is negative unless an alloantibody is also present. So how you resolve this is by testing the serum against red cells in the presence of the drug, which may cause sensitization, agglutination, or hemolysis. The eluate is negative since only complement is coating the red cells. The next type of drug-induced hemolysis is due to autoantibody production. The serological findings, which we'll discuss on the next slide, are indistinguishable from those associated with warm autoimmune hemolytic anemia. This is why the history is crucial. The mechanism of hemolysis is unknown, and the first case was alpha-methyl-dopa. L-dopa has also been implicated, as well as other drugs closely related to alpha-methyl-dopa. The DAT is positive in approximately 15% of patients receiving alpha-methyl-dopa. Only 0.5 to 1% of patients taking this medication will develop hemolytic anemia. The red cells are usually coated only with IgG, but occasionally weak complement coating is also present. The DAT usually becomes positive only after 3 to 6 months of therapy. The development of a positive DAT is dose dependent. Approximately 36% of patients taking 3 grams of the drug daily develop a positive DAT compared with 11% of patients receiving 1 gram per day. Strength of the positive DAT becomes progressively weaker once alpha-methyl-dopa therapy is discontinued, but this may take from 1 month to 2 years. Patients with hemolytic anemia due to alpha-methyl-dopa therapy improve within the first week or so after the drug therapy is discontinued. And we had a patient who, this was their problem. We're thinking it's a warm auto, but once we got the history and discovered he was taking alpha-methyl-dopa, we were able to assist the doctor in coming to the correct diagnosis for this immune reaction. The serum or plasma, it's reactive with all cells tested. The eluate is reactive with all cells tested. The key to diagnosis is the patient's history. Patient taking the medications known to cause autoantibody production. And as you can see, on the very bottom is a graphic of how this works, that the patient develops an antibody that, due to alpha-methyl-DOPA, reacts with the patient's own cells and in some cases will cause hemolysis. For nonspecific protein adsorption, the drug causes a modification of the red cell membrane, which causes proteins to attach. This is demonstrated by antibodies that react in the presence of the drug. The summary of laboratory investigation: when a patient has a positive DAT, history must include medications the patient is taking in the hospital and at home. Perform a DAT to classify the coding protein as complement or IgG or both. Perform an elution if IgG coding is detected. Test the patient's serum or plasma for unexpected antibodies. If drug antibodies are suspected, send it to a reference lab. The reference lab has the ability to coat the cells with the drug and/or introduce drug into the test system. This is the end of Unit 13. I'm hoping that you have written down questions for your instructor. And again, your book does a really good job. And listen to this presentation a couple times in order for you to get the most out of what is being presented. All 4 sections of the presentation.